Good morning, good afternoon, and good evening to colleagues joining us from around the world. Welcome to the 6th World Sepsis Congress and to this session on immunization and other prevention strategies for women and children. Friends, my name is Fouzia Shafique, and I'm the Associate Director for Health with UNICEF, and I'm honored to moderate this session today. Our session will explore the key strategies to prevent sepsis in women and children, from trained immunity and vaccination to maternal immunization and immunoglobulin approaches. We have an outstanding lineup of global experts with us today. A quick reminder to our colleagues who are joining, please submit your questions as you're listening to the presenters via the YouTube chat. We will hopefully have time for short Q&As after each presentation. With that, let's dive in. It's my pleasure, colleagues, to introduce Professor Mihai Netea from Radboud University in Netherlands. Professor Netea is a leading expert in infectious diseases and immunology. He is widely recognized for pioneering the concept of trained immunity. His work has transformed our understanding of the innate immune system. Today, he will be talking to us about trained immunity for infection prevention. Professor Netea, the floor is yours.
Well, thank you very much. It is an honor to be here today with you, and it's a pleasure to be able to share some of our work and some of our thoughts about how we can prevent infections by using trained immunity as targeting mechanisms. And the first question that we can ask ourselves is, how precisely is trained immunity and innate immune responses influencing the severity of the infection? And the concept behind that is the following. If we can initiate an innate immune response very efficiently in the beginning of an infection, when we don't even know that we have the infection, we can stop or slow the growth of the microorganism, which would result in a low pathogen load, low systemic inflammation in the individuals, low symptoms and survival. However, if there are individuals with a low innate immune responses, when they are home, they don't know about the infection yet, but that allows the microorganisms to grow, to attain high pathogen load, that will lead to inefficient systemic inflammation, high severity, and that is why, unfortunately, many of the patients die. So how can we influence these processes? And we started to be interested in this phenomenon when we have studied some old information and some old literature regarding some vaccines, such as Bacille Calmette-Guerin in the vaccine against tuberculosis. And there were old studies. This is a study from Sweden, almost 100 years ago, that showed that when BCG was introduced in the population, in the children between 0 and 5 years of age, the mortality decreased significantly from 11 to 4%. And we have to think this is before the time of antibiotics, when unfortunately a lot of children died in a high infectious pressure setting. What is very interesting is that people could not explain this strong decrease in mortality through the decrease in the number of tuberculosis deaths, because those were responsible for less than 1% of the deaths in the population. But they observed also strong decrease in neonatal sepsis mortality and mortality due to non-tuberculosis respiratory tract infections. So we try to understand how is that happening. Can we indeed demonstrate that this is the case? And we performed a study in which we used as a model of experimental infection yellow fever vaccination, because yellow fever vaccine is an attenuated virus. And we can assess the pathogen load, the viral load in this case, by doing a PCR in the blood after the yellow fever vaccine. Of course, this is a very mild infection, but still, when we administered placebo or BCG to two groups of individuals, and we administered yellow fever vaccine in all of them, what we have observed is that the individuals who got BCG vaccination had a very significant decrease in the yellow fever vaccine viremia. So basically, BCG was able to protect against a viral infection, something that we previously thought it would not be possible. What is the mechanism behind this protection? Of course, the general way in which the vaccine are working is inducing an immunological memory and TMB cells. However, this cannot explain the phenomenon that we observe here because this process of activating T and B cell memory is antigen specific. And there are no common antigens between tuberculosis and yellow fever vaccine virus. So the only possible explanation that could be is that we also activate and improve the innate immune responses in these individuals because innate immune responses are antigen independent and are non-specific from that point of view. So we assessed whether that is indeed the case, and we have shown that indeed BCG enhances not only the function of T cells and B cells, but also the functions of innate immune cells, such as monocyte in this study, in which we observe that the production of pro-inflammatory cytokines, such as TNF and IL-1 beta and IL-6, is increased after BCG vaccination, not only upon stimulation with Mycobacterium tuberculosis, but also upon stimulation with non-related stimuli, such as Staphylococcus aureus or Candida albicans, but also we have used other types of stimuli. This is explained by long-term epigenetic reprogramming of myeloid cells. What do I mean by that? During activation of a naive innate immune cells, such as naive macrophages, where the chromatin is very tightly packaged and gene transcription cannot take place because transcription factors cannot bind to the promoter of the genes, there are changes in the phosphorylation, methylation, acetylation, and so on of the histone in the nucleosome in the DNA that determine a relaxation of the architecture of the chromatin. So the transcription factors can bind easier to the promoters and induce gene transcription. After elimination of the infection, some of these chemical changes persist, like keeping a bookmark in the right place that we need to know where to open the book. So the next time that the cell is activated, the book, the DNA, can be opened much easier at the right place to activate the innate immune responses. And in this way, during the secondary infection, the response of innate immune cells is improved. And this is a process, again, that is independent of the antigen. Also, a different type of secondary infection can induce an improved response of myeloid cells. Now, this is regulated in the circulation, but we have shown that this is regulated also in the bone marrow progenitors of immune cells. So this is a long-term process that can persist and can produce myeloid cells, innate immune cells, with an improved responsiveness, also weeks and months after the vaccination. So we wanted to see whether we can indeed demonstrate that this is the case. There are a lot of epidemiological studies showing that this is happening in children, but we were also able to show that this is happening also in the adults. This is the Activate study, in which people who were in the hospital, after they were released from the hospital, they were asked to participate in the randomized trial to receive either placebo or BCG, and we followed them up for 1 year after a release from the hospital. And what we have observed, that BCG vaccination decreased by approximately 40% the total number of infections that these people got, and actually with almost 80% the respiratory tract infections. We tried to leverage this information also during the pandemic for the COVID-19 prevention and infection, but here, unfortunately, we were not able to see a difference. So apparently, the total number of infections cannot be reduced by BCG activation alone. However, what we have observed is that the BCG vaccinated individuals have much better antibody responses and cellular responses to the virus when they get infected. And that results also to a decrease in the severity of the disease. The COVID-19 related admissions were decreased by 15%. Interestingly enough, also the influenza infection was decreased. So not the COVID, but the influenza infection numbers were decreased in the BCG vaccinated group. But very importantly, what we have observed was also a decrease in the total mortality and COVID-19 related mortality in these trials. when we performed summary statistics in all the clinical trial using BCG during the COVID pandemic, we observed approximately 40 to 50% decrease in mortality in this population. This was shown not only for BCG, but there are also other vaccines, for example, adjuvanted vaccine, that can decrease the severity of the infections like COVID-19. This is a study that has used recombinant adjuvanted zoster vaccine, the AS01 Shingrix vaccine that is used now in the elderly, that have shown decreased risk of severe COVID-19 and hospitalization in older adults with approximately 30%. And similar type of studies have been shown with other attenuated and adjuvanted vaccines. All of this demonstrates that there is also an innate immunity memory that is induced by certain vaccines, that is induced through epigenetic reprogramming of the cells, and that can improve in an antigen agnostic manner, in an antigen independent manner, the response to multiple infections. That also argues that in future vaccines, we have to combine the adaptive immune memory, which is also very important, obviously, but also to combine it with innate immune memory or trained immunity to induce better and more efficient vaccines in the future. And with that, I would like also to thank you for the attention, but also thank all the colleagues who contributed and collaborated with us in all these studies. Thank you very much.
Thank you, Professor Netea. Fascinating. What you said about the innate immune system being primed in initial infections so that in secondary infections it can provide as much as 40% protection. And also the concept of the antigen agnostic reaction that you are seeing. Our participants are fairly quiet. I do not see a question in the chat. So I will ask a question, Dr. Netea, and try and encourage our participants to ask one as well. In moving forward, what do you see as the biggest barrier to implementing what we have learned about the trained immunity strategies? How do we take them to scale?
I think what it would be very important is that both WHO and non-government and governments themselves would initiate studies to demonstrate that this is the case and which are the cases and in which cases should we use this approach. For example, one direct application that it's truly needed, I think, is, for example, we have seen a very strong signal in all our trials that BCG can protect against influenza infection, both in experimental studies, but also epidemiological studies that have been done. Even in the COVID-19 studies that we could not protect against the total number of infection, only against the mortality against COVID, we have seen that the actual protection was better against influenza. Now, the chance that in the future there is a pandemic with a new influenza virus is very big. And we still have influenza around us, obviously. So one of the most important studies to be done is to do a clinical randomized trial to show that BCG in humans can protect against influenza. That is one thing to be done. In addition, we have to leverage this knowledge to design and build also new types of vaccines that incorporate this knowledge to increase the protection. And the biggest, let's say, barrier to that is actually lack of knowledge about these mechanisms and lack of, let's say, courage to apply these new mechanisms in large clinical trials. And this is the step that we have to do together.
Thank you. Thank you. That was very informative and practical things that we can do with the manufacturers, with the governments, and with the partners. We do have a couple of questions. One of our colleagues wants to know if BCG confers protection to herpes-mediated reactivation ensuing in neurodegenerative diseases, a very specific question. And the same colleague also wants to know if we have any evidence of any understanding of why BCG confers more protection to prostate cancer specifically. And then if I may, there is one other question. Do we expect to see a vaccine against sepsis? And if so, when?
Okay, so there are many
A
questions.
lot of
I
questions.
hope that I will remember them. So there is indeed a nested study in one of the big BCG trials during COVID-19 that were done in Australia by the colleagues by Professor Nigel Curtis and his group. And he performed within one of the big BCG COVID-19 studies also a sub-study regarding recurrent herpes infection. And indeed, in that randomized sub-study, there was clear, and that is published, there was clear protection of BCG against herpes virus reactivation. So that was very promising. At the same time, in general, for example, is likely that there is protection against herpes viruses. And there are epidemiological studies, for example, that BCG vaccinated and BCG treated patients with BCG for bladder cancer have less dementia and Alzheimer's disease. And that is also something that really needs to be done and really needs to be studied. Thereafter, there was a question, if I remember, let me think about
Why
the.
BCG confers more protection to prostate cancer
Oh, yes.
specifically?
Well, BCG is especially used in bladder cancer, not prostate cancer. There is very little known. There are some cases that old studies actually with BCG vaccination in prostate cancer as well, with promising results. But that was done in the 80s, and unfortunately, it was not followed. The more effective treatment is for bladder cancer, but I do think actually that future studies for prostate cancer are also needed, and that has to do actually with the local effects, but also the systemic effects and the reprogramming of the myeloid cell function, which is immunosuppressed in cancer, and it can be boosted by BCG. And the last question was about
Will we have a vaccine against
Oh,
sepsis?
against sepsis.
So when?
Well, in a way, we do have already BCG. So even in the last BMG published study in 5,000 prematurely born children in India, that was published last year, beautiful study in which newborn were vaccinated with BCG or not if they were very low in weight, so they were not standard vaccinated with BCG. We see very clearly lower incidence and mortality in sepsis. So in a way, BCG is already in this subgroup of children a vaccine against sepsis, basically, and also the severity of the infection being decreased by BCG. We can already argue that that is also because the very severe infections, they go out in sepsis. So we can already argue that that is the case.
Thank you, Dr. Netea, and thank you, Rahul and Halima, for your questions. I have a feeling you will hear more about your queries in our next talk. So let's move on to our next speaker. Thank you, Professor Netea, again. Colleagues, our next speaker is Professor Christine Stabell Benn from University of Copenhagen in Denmark. Professor Benn is a leading researcher in global health and vaccinology. She's known for her work on non-specific effects of vaccines and their broader impact on immune function. If you've had the opportunity, as I have, her talks on the learning capacities of the immune systems are absolutely fascinating to listen. Today, she will speak to us about the importance of the BCG vaccine. Professor Benn, over to you, please.
Thank you very much for that kind introduction, and also to Mihai Netea for actually also paving the road for this presentation, which will be more specifically on the importance of BCG vaccination. I'm going to argue in this presentation that neonatal BCG vaccine is a brilliant way to protect against sepsis death, and that it's a very low-hanging fruit in public health that we are currently not harvesting the full potential of. So BCG is the vaccine against tuberculosis. It's recommended at birth to children who are healthy in TB endemic areas, and it's considered a pretty mediocre vaccine against tuberculosis. So there's a huge interest in developing more protective TB vaccines, obviously, but it might have been overlooked, and we aren't harvesting the full potential of its non-specific effects. So just for the audience who might not be familiar with non-specific effects, it's now increasingly clear that routine vaccines, in addition to their well-known protective effects against the target disease, also may have non-specific effects. And this is now part of the main textbook on vaccines, Plotkin's Vaccines, where there's a full chapter 3, among others, written by Mihai Netea on the non-specific effects of vaccines, which is the concept that, again, vaccines can have broader effects and that have an immunological and clinical impact beyond protection against their target pathogen. With regards to BCG vaccine, I'll skip a lot of the earlier vaccine studies that were done on BCG to jump to 2016, when WHO published their great review on BCG, diphtheria, tetanus pertussis vaccine, and measles-containing vaccines and their non-specific effects. And in this review, it was concluded based on 5 randomized trials and 9 observational studies done at that time that receipt of BCG reduced all-cause mortality in childhood more than expected through prevention of tuberculosis. And you can see here the meta-estimate of these trials and observational studies showing that BCG was associated with almost a halving of child mortality, which is obviously much more than can be explained from prevention of tuberculosis, which doesn't kill 50% of children under 5. We contributed to this review with several trials, but also we have done trials afterwards. Here is a summary of 3 trials done in Guinea-Bissau at our field station there, where we were looking at BCG versus no BCG to children with low birth weight in 3 different trial scenarios with different underlying control group mortality in light gray. And you can see here that consistently across trials, giving BCG at birth in these randomized trials versus the usual delayed BCG vaccine to low birth weight children was associated with significant reductions in all-cause neonatal mortality. And in a combined analysis of these 3 trials, neonatal mortality was reduced by 38%. And this was mainly due to non-specific protection against septicemia, which shouldn't be something that the vaccine actually worked against. But we saw a 25% reduction in the neonatal sepsis hospitalization rate and a 54% reduction in the neonatal in-hospital sepsis mortality in these trials. And looking further into the timing of the effects in these 3 trials, we saw that there were here in the table here effects on sepsis within the neonatal period of 50%, as I already told you. But also you'll see that here we stratify by sex, and boys and girls have different effects of BCG. And in particular, we saw that boys, as is well known, had a almost 3-fold higher mortality than girls in the control group. But this was dramatically changed in the BCG vaccination groups because BCG had a particular marked beneficial effect for boys, reducing mortality 3-fold in the first week of life. So very rapidly occurring effects of BCG against sepsis mortality, suggesting actually that BCG may not only protect or prevent sepsis, but may also potentially treat some cases of sepsis. And as Mihai also alluded to, there's a new randomized controlled trial from India published last year corroborating these findings. In this study, it was very frail, very ill newborns weighing less than 2 kilos admitted to the neonatal intensive care units. In the trials, there were no deaths from TB, so every effect that was seen was unrelated to the protective effect of BCG against tuberculosis. And there was a 17% significant reduction in neonatal all-cause mortality and almost a 50% reduction in neonatal infectious disease mortality. And here in this study, beautiful study, they also collected cultures or did cultures of isolates and found that particularly the risk of having Klebsiella pneumonia was reduced in the early vaccination group. And again, the effects were seen just within the first days, supporting that BCG, again, might be treating and not just preventing sepsis. And noteworthy, the number needed to vaccinate with BCG to prevent 1 death was as low as 21. Mihai already touched upon the immunological mechanisms where his work has been absolutely instrumental in showing how such effects could occur. from a BCG vaccine against other pathogens, and also why they could occur so rapidly, because obviously this has nothing to do with adaptive mechanisms, but these innate training effects that Mihai showed so beautifully for BCG can explain why we would see such dramatically, rapidly occurring effects of BCG vaccine against septicemia in low-income settings. But there's also an alternative proposed mechanism that I want to touch upon, and that is emergency granulopoiesis. So here is a study that we also were able to contribute to, where with some human samples, but the primary focus of this paper was on urine sepsis model. And there in this sepsis model, it was possible to show that BCG induced G-CSF within hours of administration, and that was necessary and sufficient to drive emergency granulopoiesis, resulting in a marked increase in neutrophils just within a few days after vaccination, as illustrated here on the graphs. And also shown in this paper, this increase in neutrophils was directly and quantitatively responsible for protection against sepsis. So you can see how these two mechanisms can both contribute to explaining how BCG could protect against sepsis and early death from sepsis in the neonates, and also rapidly occurring effects. And maybe they both are at work at the same place and contribute both to these observed clinical effects of BCG vaccine. So I want to end my presentation touching upon the policy implications of these findings, the public health implications of these findings, because it's well known that in low-income settings, while we've had great advances in terms of reducing child mortality, the neonatal mortality remains stubbornly high. It's very difficult to intervene and reduce neonatal mortality. But it seems that from these studies that with BCG, we have a beautiful tool to reduce neonatal sepsis and death from sepsis. BCG is currently recommended at birth in TB endemic areas where deaths from sepsis are most prevalent, but it's often not given at birth. So in this study from Guinea-Bissau, we were able to show that you can see by 1 month of age, children, the BCG coverage is less than 40%. And if all health facility visits had been used, it would have been maybe 50 or a little bit more than 50%. But still, the majority of children don't get BCG within the first month of life, where it could actually contribute to reducing their risk of sepsis. So why is this? Why is the delivery of this intervention so not up to scale? And I think part of the explanation is that BCG is still perceived as a pretty mediocre vaccine against tuberculosis, and there's no incentive to give it very early on because children don't die from tuberculosis very early on. But that would change if it was seen appropriately as a vaccine against neonatal sepsis. So we have suggested the following policy changes at the WHO level. First, to update BCG recommendations to include frail, preterm, and hospitalized neonates. As we saw in the Indian trial, they benefited a lot from BCG at birth. But also add protection against neonatal mortality as an indication for BCG vaccination, which would change health facility and healthcare workers' incentive to give this vaccine, and make sure that all maternity wards provide BCG at birth, which is currently not the case. And in addition, remove the restrictive vial opening practices that are prevalent in many places, because BCG comes in 20-dose vials that are only opened perhaps once per week or once per month, and they only can last for 4 to 6 hours. So health facility will tend to gather a lot of children before they open a vial, leading to great delays in BCG coverage. And then we should use strong, viable BCG strains and ensure good vaccination technique, because we have been able to show in a modeling study using the data available globally that if vaccination coverage could be increased by 2 months of age to 99% in these TB endemic areas, and if good techniques were applied and good strains were used to get a high proportion of children getting a BCG scar after vaccination, that could globally lead to a 14% reduction in infant mortality, corresponding to more than 200,000 fewer infant deaths per year. So indeed, I hope I've been able to convince you that this is a very low-hanging fruit that is currently not harvested and just waiting to be picked and used. With that, I want to end my presentation with inviting all of you for our hybrid conference on health effects of vaccines, which will focus on the non-specific effects of vaccines, among others BCG, and it takes place in Cambridge from 11th to 13th of May 2026, and virtual registration is still open until 4th of May. So with that, thank you very much for your attention.
Thank you, Professor. I was taking notes as you were talking about recommendations to pass on to our immunization team that works very closely with WHO as well, but also an incentive for teams working in different areas of health to work together, those working on newborn and infant mortality, to be invested in immunization coverages because it has direct impact on their work. We have two questions for you. One you have partially answered already, but would be good to hear a little bit more about what are your, in addition to the three that you've already mentioned, four that you've already mentioned, how should the policymakers rethink BCG in the light of these effects that you have mentioned? So you've given us some recommendations already. If there's anything else that the policymakers should be looking at. And then one of our participants would like to know if we know why BCG confers more protection to boys than girls.
Thank you very much for those questions. So in addition to the recommendations I already mentioned, I think the most important would be to change the indication for BCG and really convey the message that BCG is not just a vaccine against tuberculosis, it can also protect against neonatal sepsis. Then I think changing the current indicators for BCG very practically might also change incentives, because currently healthcare workers in Africa, Asia, in areas where they use BCG are monitoring the success of the program by assessing the proportion who has been BCG vaccinated by 12 months of age. But changing that indicator to looking at the proportion of children vaccinated within the first month or even the first week of life would provide an incentive to vaccinate earlier. And in addition, supplementing this indicator with an indicator of the proportion of children who actually develop a scar after BCG vaccination, for instance, assessed at 14 weeks of age at the time of the third pentavalent vaccine, would also give a good indicator for the success of the program in terms of targeting children early on and with a very good and scar-inducing vaccine strain and vaccine technique. So this was the response to the first question. With regards to the second question, please remind me again, I didn't take note here. Oh, that was the sex difference, yes. So with the boys, I think we know that they are born more immunosuppressed by their mother because she simply has to have a more down-regulated immune system when she's carrying a male than a female fetus. So it might be that this is part of the explanation why they're particularly vulnerable. So as I showed you, they have threefold higher mortality than girls in the first weeks of life from septicemia. And perhaps in these children, it's particularly important to come with that early stimulating effect of the innate immune system compared with in girls.
Thank you, Dr. Benn. Thank you so much, especially for those very specific recommendations that I hope others are noting as well. I see many of our colleagues from ministries of health who are hopefully also taking note of these recommendations. Thank you. We will now move on to our next speaker, who is Dr. David Goldfarb from University of British Columbia in Canada. Dr. Goldfarb is a pediatric infectious diseases specialist and a medical microbiologist. His work has focused strongly on improving diagnostics and prevention strategies for infections in children, particularly in resource-limited settings. He will be talking to us about developing maternal vaccine strategies for low and middle income countries. Dr. Goldfarb is in Canada. It's 2 a.m. there, and therefore this is a pre-recorded talk. And we will not have Q&A time after this, but should you have a question, please do feel free to type it out and we can go back to Professor Netea and Professor Benn for those questions. Let's listen to the talk.
Okay, good morning, everyone. My name is David Goldfarb. I'm a pediatric infectious disease doctor and medical microbiologist here in Vancouver. And I wanted to first of all thank the conference organizers for inviting me to speak at the meeting, but unfortunately I had to do it virtually because it would have been at 2:30 a.m. my time. But happy to be part of this meeting. So by way of disclosure, I don't have any commercial interests, and I work for the Provincial Health Services Authority, which BC Children's and Women's Hospitals is part of. So this is an important, I believe, and emerging topic of maternal immunization, and particularly about how it applies to low and middle income country settings. I'm going to be breaking up this brief presentation, into 3 sections. One, just a bit of background and why is there particular interest in this area. I'll talk about some of the unique benefits of maternal immunizations. And then lastly, I'll speak about the challenges. There are a fair number of them in terms of implementation, but obviously these are surmountable, as we'll discuss. So in terms of background, the main concept around this intervention is that there is a process for active transfer of antibodies from the mother to baby or to the fetus. And here's a diagram showing you that process in a cartoon form, but there is maternal IgG, and it really is only IgG that gets transferred this way, but it's endocytosed within the placental on the maternal side, the in situ trophoblast cells, which have a neonatal FC receptor. And in the acidic environment of the endosome, those will bind, and then it gets transferred across over to the fetal side. And then when exposed on the fetal side to a more physiologic pH, those antibodies, those IgG antibodies, will release from the receptor and go into the fetal circulation. So first question is, when during pregnancy are most maternal vaccines given? And this ties into this physiologic aspect. Is it in the first trimester, second trimester, third trimester, any time so long as 2 weeks prior to delivery? So in terms of the answer to this, it actually is a little bit varied. We generally give most vaccines during the third trimester. We'll talk about that. There are some, though, that you can give, and depending a bit on seasonality and benefits and mother at different times, and some that the main priority is make sure it's given at least 2 weeks prior to delivery. But third trimester is generally the answer. And that's because this process really takes off at that later in pregnancy. So here is just a diagram showing what the concentrations of IgG are in the fetal serum and maternal serum. So this is actually, like I was mentioning, an active process. And you actually, by the time the baby delivers, have higher concentrations of IgG in the fetal serum compared to the maternal serum. And that really takes off in that last trimester. The other thing to be aware, and this also is relevant to some conditions, is the different subclasses of IgG are transferred more preferentially. And the one that gets transferred the best is the IgG1 subclass, and then the second generally is IgG4. But as you can see across all these subclasses, most transfer happens in that later part of pregnancy. Okay, so now we've passed through the bit of that basic physiology related to this. The important part is understanding the benefits, and there are some real benefits in maternal immunization. So it's been around actually for decades, and we'll talk about it. And many have argued it's been an underutilized platform over time. Tetanus is obviously the one that's been implemented now for the longest as a maternal program. and really on a global scale. And I'd argue it's really obviously a big success. But what's now the real interest in maternal immunization, and why is there this more renewed interest in it? And there's a couple of reasons for that. One is related to the epidemiology. And here's a diagram just showing the deaths by age and birth weight due to infectious disease in infants. And certainly you can see here, this is the US data from earlier in the 2000s. And a large proportion of the infectious disease related deaths are happening in that first month or two of life. And we certainly know that we don't have ability to administer vaccines that will mount a sufficient immune response in this age range. So as many on this meeting would know, that most vaccines are given actually at 2 months of age, often as the first. There often isn't the ability to mount an immune response to protect against infections just after birth. And so we've seen, this is a graph showing the number of child deaths over time. We've made some real improvements in the last 20, 30 years in reducing child mortality. But as you can see, it's preferentially been reducing deaths in the children outside of the neonatal period. We've done great in children 1 to 5 years of age in particular. And a lot of those reductions in those age groups are actually related to vaccine programs that have been implemented in childhood vaccine programs. But we're not seeing those kinds of reductions in the neonatal, and I'd argue also the younger infant age group. And part of that is due to the fact that a number of those infectious causes of death, there isn't vaccine programs that can address those. Similarly, this is looking at death due to pertussis as a percentage over time. And this is in the US again, but similarly now the biggest burden really is in that early infant period. And similar with RSV, we know the biggest burdens are in those first few months of life. So the way to potentially protect this group is through maternal immunizations and passive transfer of antibodies in those first couple of months or a few months of life where we don't currently have vaccines that can mount a sufficient response. The other concept around maternal immunization is that you get essentially a 2-for-1 special. So you get the direct protection. So the infant will receive the antibodies and essentially passive immunization to protect the infant. There's also the indirect protection. So many times the way infants may get an infection is through exposure to the birthing parent, the mother, and so if she's protected, for example, against pertussis or against influenza, that also helps protect that infant, that newborn, from being exposed to that infection as well. So we've had a number of maternal vaccines that are now in some places routine or implemented. That column on the left are those that are routine or implemented in large parts of the world, not necessarily globally and not necessarily widely implemented in many regions, but at least are currently and have been used widely. There's now a series of candidate maternal vaccines. Say top on that list is the Group B strep vaccines that are coming. But also there's considerations for things like cytomegalovirus, potentially malaria vaccine during pregnancy, and other things like Zika virus and E. coli. There are other vaccines that also can be given in pregnancy, like yellow fever or rabies or hepatitis B. Those are dependent on certain situations or contexts. I'll talk briefly about tetanus, influenza, and RSV and some of the aspects. So anyone who's seen a case of neonatal tetanus cannot forget it. I was unfortunate to see one case during my practice in Botswana, and obviously, it's anyone who's seen that can recognize how horrible a condition this is. So this would, I'd say, is the biggest success globally of maternal vaccines is the rollout of maternal tetanus vaccination. And here's just a graph showing you the number of cases. And initially it was implemented as part of routine immunization, but then there was intensified immunization with annual mobilization campaigns that really increase the amount of vaccinations we're getting during pregnancy. And you can see those numbers have come down dramatically, such that it's rarely seen, fortunately, globally now. Influenza is another one that's been recommended for quite some time, and the US CDC is recommended from the 90s, WHO recommended in 2005. And it's a 3-for-1 in that there's also benefits to the pregnant woman in terms of high risk of influenza infection, both severe complications, including death from that. So it's protecting both. So you get a 3-for-1, the direct infant protection, indirect infant protection, plus maternal disease. And there was initially some data that helped support the WHO's recommendation in 2005 from Bangladesh. And then RCT in South Africa also showed both protection for mothers as well as infants. And RSV is a newer kid on the block in terms of maternal immunization. One of the areas of consideration is that there's several potential approaches. There's also infant passive immunization programs that need to be considered as well. So what are potential challenges? And unfortunately, this list is fairly long, and I won't be able to go into all of them, but these are various aspects: antenatal care, access and timing, health system delivery constraints, financing and affordability, policy, regulation, coordination. There's also concepts around safety perception and vaccine hesitancy, cultural and gender dynamics, surveillance and monitoring, which are often difficult to or haven't been performed in many parts of the world, and then communication demand generation. Overlying all of these are the equity gaps that we also see in these spaces, particularly in LMICs. There's also, on the physiologic side, there's women that were more likely to have hypergammaglobulinemia, and that'll be seen in HIV, for example, and malaria, and that may reduce the amount of the actual pathogen-specific antibodies that make it through to fetus. So if you look at RSV and influenza, you can see, and tetanus, that there are different aspects. There's timing sensitivity that in tetanus isn't very important, but very important in terms of RSV antibodies. There's cost pressures that are quite different. For example, on the RSV side, you have high cost pressures for those vaccines at present, at least, but not so much on the tetanus vaccines. The complexity is lower for the program, simple schedules, and higher for things like RSV or influenza. Influenza needs to be given annually, for example, which is different than tetanus. So the other aspect to consider are the ethical questions. So shift historically have been from protecting women from research to now understanding that we have to protect women through research. There's a precautionary principle that sometimes healthcare workers and pregnant women tend to be more cautious when it comes to pregnancy. And the concept of a vaccine that's only protecting the fetus and not necessarily the mother, such as RSV, also needs to be considered in terms of options potentially for opt-out. So in summary, maternal immunization is a powerful but underutilized platform. Established vaccines demonstrate proof of concept with a growing pipeline that are including exciting possibilities with Group B strep, CMV, malaria. Implementation in LMICs faces real but surmountable barriers, requires ANC integration, health system strengthening, and equitable access. And then ethical frameworks really need to evolve, and particularly the concept of protecting women through research is now more of a moral imperative. So I will end my presentation there and thank you for your attention.
Thank you, Dr. Goldfarb. Thank you also for summarizing the key lessons from everything that you've presented towards the end of your talk. As we don't have Dr. Goldfarb with us to ask questions, we will move on to our final speaker. And our final speaker today is Dr. Antigone Kotsaki from University of Athens in Greece. She is an infectious diseases specialist with a strong research focus on immunology of sepsis and how immune responses influence patient outcomes. She will speak to us on immunoglobulin preparations, treatment, or prevention. Dr. Kotsaki, the floor is yours.
Thank you very much. It's an honor being here with you today. First of all, greetings from Athens, Greece. So in the next few minutes, we will focus on immunoglobulin preparations in terms of sepsis treatment, whether it is prevention, primarily for neonates, or as an adjunctive immunotherapy for critically ill septic patients. These therapies have been studied for decades, but their implementation in clinical everyday practice remain controversial. So we will focus on three aspects: what we already know, what remains unclear, and whether their use is of value today. So treatment with immunoglobulins is very attractive when it comes to sepsis. And why is that? Immunoglobulin treatment addresses several issues in several pathophysiological pathways simultaneously, whether it is opsonization clearance and subsequent clearance of invading pathogen and endotoxins. And through the opsonization and clearance of endotoxins, the indirect effect on immunothrombosis, or whether this is the prevention of non-specific complement activation. Here I have to underscore that the preparations for immunoglobulin, they are not equivalent. We have intravenous polyclonal immunoglobulin, that is a blood product prepared from a pool of donors that contain approximately almost IgG, and then we have them IgM and IgA enriched preparations. So we return to sepsis pathophysiology and the role of immunoglobulins. Now they know that they're implicated at impaired host defense, at immune dysregulations, and we know that the majority of patients that present with septic shock present with low levels of immunoglobulins, and this is attributed primarily to increased capillary permeability and increased catabolism through consumption. So we have a biological, a scientific rationale robust for the use of immunoglobulins in treatment of sepsis. But we have many trials, and these trials have harvested contradictory results. This is a small trial, but it's a pivotal trial. This included 29 patients with septic shock, and their low levels of immunoglobulins were associated with greater vasopressor requirements. Patients were more likely to develop acute lung injury, and they had higher mortality. So this study demonstrated that there is a subgroup of patients with impaired humoral immune response that the administration of immunoglobulin may be beneficial. And if we focus on IgM, this is a study from the Hellenic Sepsis Study Group. 332 patients were enrolled. There was an innovative approach. As you can see, patients were stratified in 4 groups. Remember, we are 2013. We do not have new sepsis definition, so we have serious sepsis, severe sepsis, and septic shock. And we follow their patients and their trajectory through clinical deterioration to severe sepsis or septic shock with repeated sampling. And we came to the conclusion, you can see that to your left, that low levels of IgM are correlated, statistically significant with increased mortality. So we come to Survival Sepsis Campaign Guidelines 2016. They were not convinced. Yes, but they shift the focus to IgM-enriched preparations. And then again in 2021, although they had more data, more RCTs, more meta-analysis, they were still reluctant because quality of evidence were low, many high risk of bias, single-center trial, small sample size, undefined randomization, allocation, blinding procedure, dosing regimens, and of course we have to highlight the cost effectiveness, because if we have a therapy, a treatment, an approach that the benefit is marginal but the cost is high, then I understand that we're super cautious. But among those meta-analyses, there is this significant study I found particularly interesting. This is a forest plot, and here we see 19 studies, over 1,500 patients. The primary endpoint was death, so the events are death. Pool estimates indicated that mortality rates were significantly lower in patients who received IgM-enriched preparations. And the odd ratio is really impressive, 0.60. And this is again a work by the Hellenic Sepsis Study Group. More than 1,300 patients screened for eligibility. After matching, we concluded in two groups, 100 patients as a control, 100 patients receiving IgM, ICU patients, critically ill patients. Interestingly, unfortunately, this is a problem in Greece. Many patients suffered from MDR and XDR, primarily gram-negative patients. And we see here, this is impressive. We see the difference in mortality between patients receiving pedaglobin and patients at the control group, 39% versus 58%. And if we perform a sensitivity analysis, this effect is more prominent for patients suffering from XDR pathogen infections. And what about late onset sepsis? As depicted by breakthrough bacteremia, patients treated with pedaglobin presented later with breakthrough bacteremia compared to placebo. And this is a relatively recent study from Nierhaus and Professor Nierhaus and his team. I think this is a game-changing publication because I think in this study we discuss about precision immunotherapy, and Nierhaus investigated the impact of pedaglobin treatment in patients with distinct sepsis phenotypes, the hyperinflammatory phenotype and the immunoparalysis phenotype. And the conclusion is that if your patient is unstable, you can use the measurement of immunoglobulins as biomarker and add pedaglobin for up to 5 days. And now we have to discuss about neonatal sepsis, and we know it is underscored that we know humoral immunity in the human newborn is provided primarily by maternal IgG. This is transferred transplacentally. So premature infants with lower levels of IgG at birth, they are prone to infections and they're prone to sepsis. And there's also an inverse correlation of birth weight and rate of neonatal sepsis. So exogenous intravenous immunoglobulin seemed a very promising approach. Unfortunately, in this study, the benefit for sepsis prevention was marginal, and there was no clear benefit for prevention of late onset of nosocomial infections. And these are two review studies. And again, the impact of IVIG administration is modest, and unfortunately, it does not include mortality. And although newborns are deficient in IgA and IgM, studies including pedaglobin here did not show any improved outcomes. And you can see at the bottom of my slide a review from Lancet, and they still further corroborate the fact that there is insufficient evidence from 10 RCTs or quasi-RCTs to support the use of intravenous immunoglobulin. And I have to remind you that the INI study that involved more than 3,000 newborns was also published in Lancet and show no benefit by the use of intravenous immunoglobulin. So, Surviving Sepsis Campaign Guidelines, we are 2026, published in March. Again, for children, they suggest against the routine use of immunoglobulin, and there is no change in recommendations for adults. And as a take-home message, treatment with IgM-enriched preparations can serve as an adjunct therapy in adults suffering from septic shock. We have proved there is a survival benefit. We have proved the biological rationale, and there's real data showing that the subgroup of patients that can benefit more are patients suffering from infection from multi-drug resistant gram-negative bacteria. Treatment with other preparations still there is no recommendation. The evidence are weak, and especially for children. No clear benefit for neonatal sepsis, not recommended for prevention in neonatal sepsis. Thank you very much for your attention, and I hope to see you all next year in our Congress for the European Shock Society in Cologne at September. Thank you very much.
Thank you so much, Dr. Antigone. That was very interesting, but it was a lot of information. You took us almost through a decade of learning in the immunoglobulin use. So it was clear where the immunoglobulins are not recommended, but you gave us many scenarios where they do work. So if you could synthesize it for us in a couple of sentences, which are the patients in which we have evidence that the use of immunoglobulins is the strongest? Where is the evidence strongest for which group?
Not neonates, not children, but adults, that they are not improving. You measure, and if you have low levels, you can add pedaglobin. And to be honest, I believe in pedaglobin. We have used it. It's difficult to use it because it's not authorized for sepsis, but in Greece it is possible. And we have shown benefit. We have seen benefit.
Thank you so much. Thank you to all our speakers for an excellent and insightful session. We've heard a range of perspectives highlighting the critical role of prevention in reducing the burden of sepsis amongst women and children. Thank you to our global audience for your engagement and for your questions. Colleagues, we encourage you to continue the conversation. Please visit the World Sepsis Congress website. Please support the World Sepsis Declaration. And finally, I would like to thank all the speakers and the sponsors for making this session possible. Thank you and enjoy the rest of the Congress. Goodbye, everyone. Have a very good rest of the day.
You too.